Just a quick reminder, you can ask questions via Slido. Don't hesitate. And it's my great pleasure to introduce you to Rod Whiteley, that you probably know. He's the head of the department, Rehab Department.
No, not the head.
Co-director?
Yeah.
Assistant director?
Art director.
Oh, okay. Of the Aspetar Rehab Center in Doha. And he's coming from Sydney.
Yeah.
Yeah. And he's going to try and have a little debate about imaging.
Merci, chérie. So today's debate is, do we really need imaging? And I'm going to explain to you why Carles was wrong in the last 15 minutes. Well, some of the reasons he's wrong. He's wrong for a lot of reasons. But mainly, we are told that imaging is going to tell us about diagnosis, prognosis, and therefore it adds value to the consultation. Imaging doesn't do that. It hasn't worked, it won't work, and I'll explain why to you, and then it should be obvious too that it just doesn't add value. Now, these days we have lots of modern imaging tools. It'd be unfair of me to say that we just heard from one, so I'm not going to say that, because today I want to talk instead about these victims of modern imaging tools. And the victims of modern imaging tools are our patients. Our patients increasingly are getting bad care because of our overuse and over-reliance on imaging. Now, my opponent in today's debate would just tell you that you can tell everything you want from just taking a picture of them, and I'm afraid that the picture tells a really different story. Like really, Carles, 39? Come on, man. So what my opponent will tell you is that I can look in a room full of all of you with injuries and not injuries, and like a game of Where's Wally, we're going to find out this is the person who has the injury. The problem is, if I take an image of all of you, we find an injury in all of you. And that leads to this conga line that starts with the imaging. First we get an image, now we get another diagnosis, now we get, and we end up with this conga line of treatments, and poor old physio, activity, load management, sitting over there bored and lonely because he can't take a picture, she can't take a picture, and it's the one therapy we have that actually works. So we want to talk about diagnosis, prognosis, and because I'm going to tell you imaging is no good, what should you be doing instead? We've touched earlier with Fiona and Pete talking about the problem of overdiagnosis in injuries, in imaging, I should say, and a recent systematic review looking at, as you can see, over 7,000 papers will tell you if I image the spine, in 1 in 5 people I'm going to find something. In cardiac regions, 1 in 3. In chest, it's going to be up to half. And if we take all of those things together and look at what are the unintended consequences of this in the things that we look at, neck, shoulder, low back, hips, knees, ankle and foot, that's in the sports medicine area. Across all of these areas, somewhere between 2/3 and basically 100% of people, you're going to find things incidentally, these incidentalomas. We see an injury, it's got nothing to do with the patient's presentation. But really worryingly, the imaging will only change your care 1.3% of the time, with a confidence interval of 1.3. So it can be as low as 0%. And in putting this together, we could have literally spent the entire day showing you, okay, here's another condition where all of the imaging shows this and it's got nothing to do with the clinical outcome. So I said, I'll limit myself to a paper that came out in the last month. So here's athletic groin pain, for example. MR findings in asymptomatics and symptomatics, whether it's bone marrow edema, bone spurs, disc extrusion, labral tears, acetabular. You see that all of these things, you'll find it equally pretty much in the asymptomatic and symptomatic patients. So it just doesn't help us accurately enough with diagnosis. Well, what about, well, it can tell us when the patient's ready to go back and what we should be doing with them. And true story. So back in 2009, 2010, remember when PRP was going to cure everything? So what we were sold was muscle injury, inject some PRP, and the next day, shazam, your muscle is healed. So we were doing this study on PRP versus platelet-poor plasma versus no injection, and we had to have criteria-based return to play, because if it was doing what they told us it was doing, if the people healed after 1 day, 2 days, whatever it was they were telling us, then there's no point having a program that says, well, inflammatory phase goes for this long, and then you rehab for that, and then you, because the effect of PRP was going to get washed out. We truly believed what was going to happen. So the very first patient that went through our study, He met all our criteria to go back to return to play, and it's 20 days, and he's done everything. Gets sent back to the doctor, the sports physician. Let's call him Robert, because that's his name. So Robert says, all grade 2 hamstring injuries take 4 weeks. So those beliefs influence his expectation, that influences his behaviour. He never lets hamstring injuries go back before 4 weeks. And then he tells us that, look, everybody knows hamstring injuries. Those outcomes reinforce the beliefs. Our grading systems just aren't working, and I'm going to show you why they aren't helping. So why we said bye-bye MRI, and I love the fact that everybody who cites our paper hasn't even read the title. Hamstring injuries and predicting return to play. So what we showed in that paper, and what still stands up, is our imaging findings don't tell us enough about prognosis. So we'll touch on some of the data from then and update it now. This was Jan Ekstrand's work on the UEFA group. This is just in hamstrings, when they looked at all the hamstring injuries graded from 0 to 4. And this on the vertical axis here is how long it takes to come back to play. So you're getting a hamstring injury, and we're told that you need to get an MRI so we can appropriately predict how long they're going to come back to play. Well, the issue is 85% of those patients are going to be grades 1 or 2. And the time to return to play for grades 1 or 2 completely overlap, and they also overlap with grade 0. The only difference you can say is some of the grade 3s take a little bit longer. Is it worth getting an MRI for them to do that on day 1? All right, well, that was an old grading system. It's been around for such a long time. Now we've got the BAMEC system, and that's completely revolutionised things. Well, BAMEC 0 up to 3B, the middle half of those all completely overlap. But there's this suggestion that these type C injuries, injuries that involve the tendon, they actually take a little bit longer. So let's look at that. When the intramuscular tendon came out, and these were the 7 papers that got a lot of press on this, and it was 7 papers, I should, based on only 27 participants. So the rest of them were editorials. Thanks, Karam. The only time for return to play, and the argument here was, once you identify one of these, all of these guys have got to get surgery. And it took 3 months for surgery to come back. So we're not talking about free tendon here, we're talking about intramuscular tendon. There's a couple of different ways you can look at it. You can either say cross-sectional area by taking serial ones, or you can say that I can see loss of tension in the longitudinal views of those. And we looked at everything. So this was 450 odd patients that we were able to get 70 of those, with intramuscular tendon injuries. And when this happened, it was after we'd just done that hamstring study, and our median time to return to play was 3 weeks. And you have to trust me that I tortured this data, because there were a couple of patients who took 4 weeks, 5 weeks. One ungrateful patient even took 6 weeks to get to bed, which obviously can't be because I'm a bad physio. There must have been some other reason for it. So I really wanted to find that the intramuscular tendon was the reason why these people took such a long time. And I absolutely tortured these data. Ultimately, it didn't confess anything, because on the left side there, if you're looking at with no intramuscular tendon, less than 50%, up to 99%, 100%, no difference except maybe at the group level a tiny little bit more, but you can see a large overlap. And we have people with complete intramuscular tendon tears that get back to play in 15 days. Waviness, yes or no, a little bit better delineated, but again, massive overlap. You cannot make clinical decisions based on this. Oh, and by the way, the return to play time, our slowest patient took 51 days. Surgery takes 91 days. So if we're saying we need to do this so I can feed you off to surgery, good luck arguing to a patient that, well, we don't know if this has anything different to do with your outcome, but I can guarantee you if you get surgery, you're going to take at least 4 weeks, probably 6 weeks longer than if we don't get surgery. All right, so intramuscular tendon, maybe it takes a little bit longer. The surgical outcomes still haven't been published on this. But there's a new kid on the block, the hamstring T-junction injury. So this was published, again, Australians were involved in this, so you always need to be careful of that. These guys describe this injury of the so-called T-junction of the hamstring. So this is the junction between the short and the long head, and if you squint a bit, you can see it's kind of shaped like a T. And the notion here was, or the point that they made was, look, half of these people are re-injuring. And since that got published, it received a lot of attention back in 2017. And more recently, the group from the UK who deal with a lot of Premier League athletes say that, look, because these get, we already know these get so many re-injuries, you need to operate on all of these. So again, we thought, well, hang on a second. What's going on with this? Should we go back and check what's happening? Just recently, literally in the last week, an editorial was published on this in the British Journal of Sports Medicine, and I'm going to show you some data that we sent to the British Journal of Sports Medicine. They were quite happy to publish this editorial saying T-junction injuries are really important based on no data, but they wouldn't even send our paper out to review. But I'm not bitter. So our radiologists went back and looked at the long head injuries, short head injuries, and these so-called zipper injuries, all the different flavours of these. We wanted to know, are we getting more re-injuries? Have we been missing these? So we get about 100 hamstring injuries a year, and we get about 400 T-junction injuries. We had to lose some of those for different reasons, so we ended up being able to track over 300 of these for at least a year. So on this axis here, this is called an event plot. So the dark black lines are 500 days. So 500 days out to 2,000 days. And that very first line going across there says, that was the last thing I found in the medical records, and that said that person didn't get another hamstring injury. The blue dot up there says that that one did get a hamstring injury, and the orange one was when somebody had an injury in their left and their right leg. And we're able to follow these people up, as I said, for a minimum of 1 year out to a maximum of 15 years. And for all of those patients that we're able to look at, which wasn't prospective, it's retrospective, mostly they're football or soccer players, mostly they're in their late 20s, and we looked at it whether it's a zipper injury, a short or long head injury. We looked at BAMIC grading, we looked at 3-scale grading, and again, I tortured these data, as well as looking at the median time to return to play, which was 4 weeks for these patients. So should we be sending all these guys off to surgery based on an imaging finding? Nothing structural, nothing functional. Well, when we look at it at 6 months, 1 in 33 is re-injuring. At 1 year, 1 in 17 or so is re-injuring. And lifetime, median follow-up for this is 7 years, is only about 1 in 7 of those guys is re-injuring. So should we be operating on these? I'm not entirely sure. The only thing that did come out of the data is that those who did re-injure did take a little bit less time to come back to play, but there's a huge overlap and that wasn't significant. So essentially the same story here, whether it's intramuscular tendon or it's T-junction injury, is that they take a tiny little bit longer to get better. There's honestly no difference in re-injury rates with these guys. And where are these surgical outcomes? I'm waiting to hear from that. One of my heroes in medicine is Sir William Osler, who first pointed out, well, firstly, the most important thing is this guy won Best Mustache in Musculoskeletal Medicine 4 years running. Nobody else has ever done that. But he pointed out that the importance of adopting new treatments early while they still worked. And I want to update that a little bit to say when a new diagnosis comes along, you really need to make this diagnosis so you can operate it on early while it's still valid. So the only thing degenerating here is really our diagnostic accuracy, and imaging is not going to work for the foreseeable future. We've talked a bit about muscle injuries today, and we're going to explain to you basic science why that's the case. At imaging, we can see fascicles, but injuries happen at the muscle fibre level. These are 0.1 of a mil thick. If I had hair, that's about how thick they'd be. When MR first started in 1979, that was the first ever MR. Got up to about 7 Tesla in 2013, gets up to maybe 12 Tesla in 2021. But the basic science looking at experimentally induced muscle injury in humans, not small animals, which is really important. So the strain model here was they stuck people on an isokinetic device and they gave them an added electrical stimulation and made them do 200 repetitions. And we've since replicated this study and found exactly the same thing. And then took biopsies of the healing muscle injury in these volunteers. So the same as Abigail Mackey and Michael Kerr did, take the biopsies at 0, 2, 7 and out at 30 days. The original basic science stuff was done, what you did was you get volunteer small animals like rabbits, they love volunteering for this sort of study, and you get a lead weight and you drop it on their muscle and crush it. And that's what all of those studies that say, look, there's this much inflammation and then this and this and this, that's what happens with crush injuries. We don't see crush injuries that much in sports medicine. We see strain injuries. What happens at strain injuries is eccentrically they overload and then a single fibre pops. And when that fibre pops, this is the schematic of what's happened, it sheds its cell wall, that cell wall attaches to an adjacent healthy fibre, that becomes the scaffold, and you regrow a new muscle fibre. So this is at, if memory serves, 7 days. You can see an undamaged fibre there. So we need to see the undamaged fibre, but more importantly, we need to see where the fibre itself is regenerating. This was the killer image from that slide. So we've got a damaged fibre up the top there and an uninjured fibre directly below it, which you can see vertically here. And that dotted line there is the same image taken in cross-section across there. So the first thing to see is that damaged fibre is full of satellite cells. Within 18 hours, the satellite cells are down there. The injury says, send the satellite cells down there. Now, satellite cells, the guys who just discovered this via Piezo won the Nobel Prize for doing this, and rightly so. They'll come down there, but unless we put load through them, they say, okay, false alarm. The satellite cells sitting in healthy muscle, they're sparse. You can see one just here and another one just across there. They're sitting there in all of our muscles, and we do some resistance training. They say, oh, you want me to grow more muscle? That's fine. This is what we're trying to inject with so-called growth factors. Why would you try and inject it? They're full of these things already. All we need to do is talk to them correctly. You talk to them by putting load through them, and they'll grow more muscle for us. But if we want to track healing, we need to be able to see it at this resolution, down at that 0.1 of a mil. Our resolution currently is like this, and the resolution on MR we need is about like that, to be able to see injured fibres and not injured fibres. We cannot get to that level because we're bumping up against the inverse square law. The only way we can do it, the magnets need to be so big that all you can do is put dead rats inside, and the reason they need to be dead is even your heart beating generates enough movement that 0.1 of a millimetre means you get motion artefact. So that's why MR is not going to work. So what do you do instead? You take a history, you examine your patients. This is the best high resolution in. Our treatment is loading. Adjust the loading. Whatever happened yesterday, until those guys at CERN invent a time machine, that's finished. Yesterday is over, we did whatever loading we did, and today our patient is either the same, better or worse. And depending on whether they're the same, better or worse, we change their loading. So how do we know if they're the same, better or worse? That's the research that we should be doing. So we checked everything associated with hamstrings. This is about 700 patients with hamstring injuries that we looked at over a long period of time. We checked every possible assessment to find out most of them were a waste of time. So the way that we looked at all of these was lined it up from 0% to 100% of their rehab, and whatever the measure was is on the vertical axis there, and depending on how much of the variance explained, we decided whether that was a useful or a not useful test to do. The best one was the length of pain on palpation as a percentage of the maximum, and your key take-home message there is when the pain drops down to a third of its original length, you're about halfway through rehab. So Carlos's patient, who still had some mild discomfort, he's not ready to go back to play. When they are pain-free, they're about 90% the way. The only strength measure that was any good, and this is an important one for us to see, you've noticed the shape of this curve, it's non-linear. It gets up to 90% about halfway through rehab, and then it tracks quite slowly afterwards. This was our best measure. We measured a whole bunch of different strength measures. Importantly, the strength tracked really closely with how fast the patients could run. So looking at how fast they said from 0 up to 100% and what that outer range strength was, that tracked pretty closely with how our patients could get back to running. Now, in presenting this previously, I realise I've done you all a little bit of a disservice because I'm presenting to you the group averages, and groups are made up of individuals, and what you need to do as clinicians is to take that information, I know what's happening at a group level, and be able to apply that at an individual level. So I see my patient on any given day, and if their strength has just dropped down, and yesterday we did some really hard training, so what do you think that means? Well, the same as if you'd done any really hard training for any other muscle, I can't train just as hard with it today. So in summary, we don't need more imaging because it's over-diagnosing things that don't matter. That freaks our patients out. They get terrified because of this, and the only thing that worsens because of all of this is our patients' anxiety, as Pete and Fiona talked about earlier. That starts off this therapeutic cascade of over-treatment that is just not warranted for most of the things that we're seeing during the day. So what I want you to say is to namaste away from the scanning day, skip the scan and trust the exam.